Good day, everyone. This is Dr. Ezi, and these lectures are made for the MRCS Part B exam candidates. The examinations are going, in some places, will be within less than 1 month. So we are going to conclude some stations here that if you attend here, you may not need to study them again. So you are going to get all the questions, all the ideal answers for the station, and if you wish, you can like and prescribe this video so you can follow until you get your examination, and I wish you all good. So today actually we are going to discuss some sort of station which is a straightforward station, and it is a critical case station again, and it's the steroids station. Okay, it's about steroids. So they are going to tell you about a patient, and this patient is actually a rheumatoid arthritis patient who is taking steroids. Some people like to call them immunomodulators because they reduce the level of immunity. And usually steroids are given to people who has deficiency, primary deficiency in steroids, or because of some immunological reasons. So you need to modulate and reduce the level of immunity due to the adverse action of immunity against the body of the patient. Okay, so this is not important only for the surgical patient, surgical doctor, or for the exam, but you need to know it because it is a critical and a fatal topic. Okay, so the questions are going to be straightforward. They're going to ask you very simple questions about anatomy in the beginning, and they're going to ask you about the layers of the adrenal cortex. As you know, the steroids normally are released from the adrenal cortex. So they are going to ask you about the layers of the adrenal cortex. Remember this suffix or this abbreviation. It is GFR. GFR is related to the kidney, and it is for glomerular filtration rate. Here in this case, in the steroids, it is related to the abbreviation of the adrenal gland is just above the kidney, so you can remember it during the stressful time of the exam. Okay, so GFR here, G is for the first layer is zona glomerulosa, and the second layer is zona fasciculata for F, and for the R it is zona reticularis. So regarding the zona reticularis, actually it releases sex hormones, and it is this type of hormones is not related to your station here. Okay, so you are going to be concerned about the zona glomerulosa and zona fasciculata. So zona glomerulosa is going to release aldosterone, okay, which is related to the minerals, your sodium, your potassium, and so on. And zona fasciculata is going to release cortisol. Okay, this is the first question. The next question is going to be what are the actions of aldosterone? Okay, so as I told you before, it is related to minerals, so it is called mineralocorticoid. Okay, what does it do? It does very simple things and very straightforward things. It is related to 4 things. Remember this. Aldosterone is related to your sodium, it is related to your potassium, it is related to your water balance, and it is related to your pH. Okay, so number 1, the aldosterone causes reabsorption of potassium and reabsorption of sodium and excretion of potassium in the distal convoluted tubules and collecting ducts. So in this way, you are going to keep sodium and excrete potassium. What is the logical action that is going to happen because of this? Water follows salt. So this will affect your water balance because the water will follow the sodium. So there will be water retention in this case, and because of the excretion of potassium, as you know, potassium is related to hydrogen ions. So if you release potassium and excrete potassium, this will lead to the release of hydrogen ions also, and this will lead to metabolic alkalosis. So number 1, the action of aldosterone, it reabsorbs sodium, and in this way it's going to retain water, and all this happens in the distal convoluted tubules and collecting the gas. Remember that. So you are retaining sodium, accordingly you are retaining water, and you are excreting potassium, and in this way you are excreting hydrogen ions, and this will lead to metabolic alkalosis. Next question here is going to be about what are the actions of cortisol. Okay, cortisol, which is released from the fasciculata zone. Okay, so the action of cortisol, actually, simply just remember that and put it as a paradigm. The cortisol increases the level of sugar in your blood, okay, or in the blood of the patient. So if cortisol is high, it's going to raise the glucose, blood glucose in the blood. So what does that mean? It means that it is anti-insulin, right? It is opposite to insulin action. Okay, number one. Number two, it affects gluconeogenesis. Gluconeogenesis, what does gluconeogenesis does? It raises the glucose also in the blood. Okay, it affects and stimulates lipolysis, and from the lipids backbone you are going to produce glucose also. Okay, it is the only thing that it causes its formation here is the protein in the liver, so it stimulates the protein synthesis in the liver. Definitely, because of all what is going here, it's a metabolic hormone, so it has a metabolic effect. As you know, there is aldosterone, for example, has a metabolic effect of metabolic alkalosis. So this also hormone has a full metabolic effect on increasing glucose breakdown, formation of glucose, more glucose, and releasing more glucose in the blood, which is anti-insulin. Okay, so it has a metabolic effect. It has an immunosuppressive effect and anti-inflammatory effect. So you want to know that the person who is taking steroids has low immunity, and actually his inflammatory response is poor. Okay, so it has anti-inflammatory effect, cortisol. Okay, so finally, the cortisol affects the body stress response. Okay, so usually cortisol is released in the morning, so people wake up in not a good mood, then after that it started to go down and the people start to get better. Okay, so these are the actions of cortisol. In general, it is anti-insulin, has an anti-insulin effect. It raises the glucose in the blood. If you mention this only, you are going to get the question. Okay, so let us see the next question. The next question is going to be tell us about how does cortisol get released from the adrenal cortex. So there is an axis. This axis is called the HPA axis, and they are going to ask you, please describe the HPA axis. Okay, so H is for hypothalamus, P is for the pituitary gland, and A is for the adrenal gland or adrenal cortex. Okay, so you are going to mention that hypothalamus releases what is called CRH. Okay, which is it is abbreviation for corticotropin, C for corticotropin, and R is for releasing, and H for hormone, corticotropin releasing hormone. Okay, so hypothalamus is going to release the adrenocorticotropin or corticotropin releasing hormone, CRH. So this hormone acts on receptors on the anterior pituitary gland, on the anterior lobe of the pituitary gland. Okay, due to this effect on the anterior pituitary gland, the anterior pituitary gland is going to release what is called ACTH. ACTH, and ACTH is an abbreviation for adrenocorticotropic hormone. A, adreno, C, cortico, T, tropic, H, hormone. Actually, you can mention the abbreviation only, but if you want to be professional, you want to mention the whole name. Okay, so this ACTH hormone is going to act on receptors on the adrenal cortex, on the zona fasciculata, which releases cortisol. So when it does that, cortisol is going to be released. One of the most important points that you are going to mention at the end of the answer of this question is that there is a negative feedback mechanism which cortisol plays by working on the anterior pituitary gland to stop releasing ACTH and on the hypothalamus to stop releasing CRH. So in this way, the axis is going to be inhibited. Okay, so this is the question of the HPA axis. Okay, let us go to the next question. And the next question actually is a simple question, and you can mention what you can in this case here. So they are going to ask you, what is your advice for a patient who is starting steroids? Actually, this is a physician's question, but as you are surgeon, you are going to do operations, and some of the patients are going to have steroids in their life sometimes, so you want to know the answer. Okay, so what is your advice for a patient who is just starting steroids? You have just prescribed steroids for him. The most important point that you want to know, and if you mention this alone, you are going to get more than 50% of the mark, is that the patient should not stop the steroids abruptly, suddenly. This is not acceptable. Why? Because he is going to develop what is called a Addisonian crisis, which is actually fatal. Okay, so firstly, you want to mention to the patient that don't stop your steroids suddenly. Okay, if you want to stop it, you have to get back to your physician and you want to taper it, so you are going to reduce it gradually. Okay, this is the first advice and the most important one because it is fatal. So what else? You want to if he visited any doctor for surgery or for a physician or any other sickness, he has to mention that he is on steroids, or sometimes he needs, if he is not well educated, he needs to carry with him a sort of steroids card, or he wants to put some sign, media alert sign that will show that he's taking steroids. Same like diabetes. Actually, for patients with diabetes, they need to show by some way that they are diabetics, also with steroids. Okay, you want to mention to him that there will be an increased possibility of infection and there will be a delayed wound healing because you are affecting the immune system here, and the steroids actually may lead to some weaknesses like osteoporosis, so fracture may happen. The patient may develop may build more weight, so like central obesity, the buffalo hump, as you know, with the steroids, and like cushingoid appearance. Okay, with taking steroids or cortisol from outside, you want to mention to the patient that and this is actually very risky and very bad regarding steroids, that if there will be a problem in sugar control. So the blood sugar is going to increase, as we mentioned before, that the cortisol is anti-insulin, has an anti-insulin effect. So the sugar is going to increase. Okay, so if he is diabetic, there will be a poor control for his sugar, and he has to expect the complications of high sugar all the time. And if he has no diabetes, he is going to develop it most probably, and that is so sad regarding the steroids patients. Another thing you want to tell your patient, you want to tell them that there may be, as we mentioned, there are many weaknesses. We mentioned the bones in osteoporosis. There will be weakness in muscles also, and there may be some sort of change in behavior, and they are at high risk of peptic ulceration, so they do not want, for example, to take non-steroidals, steroid anti-inflammatory drugs, which will make the situation worse. Okay, so these are about 9 or 10 points you want to mention to any patient who visits you when you start him or her steroids. Okay. Now they are going to come to the critical part of the station, and the critical part is related to the Addisonian crisis. So Addisonian crisis, as I mentioned before, they are fatal. Okay, so they are going to ask you, tell us about Addisonian crisis, or they may be going to ask you in parts the questions. So the question is going to be first, is about what is the definition of Addisonian crisis. And the definition is that it is the acute reduction of the circulating steroids, okay, due to some reason. Okay, it is Addisonian crisis means that there is just a drop in the steroids level in the blood, okay, the circulating steroids. So this is the definition. That is why I told you before, when you start steroids for some patients, you want to tell them that you have to be careful. You cannot stop it abruptly because you can develop fatal condition, which is called Addisonian crisis. Okay, so this reduction could be due to two reasons, either a primary cause or a secondary cause. Okay, so for example, regarding the primary cause, this most probably is because of, due to any cause, there is a sudden reduction in the adrenal supply of cortisol. Okay, so the level is not meeting the requirements of the body. This is primary. Okay, primary coming, what is meant by primary? There is a problem in the adrenal gland itself, okay, or adrenal cortex. Secondary, it could be because of, it is due to something from outside that has affected the level of the hormones in the blood. So for example, the patient is taking steroids and he stopped them suddenly. So this can cause this. Other causes include trauma, surgery, and infection. All these are secondary causes. Okay. The third question regarding the Addisonian crisis is going to be, what are the cardinal features of Addisonian crisis? Okay, and in this case here, there are actually main four features that you want to know. Okay, number one, there will be some GI features, abdominal pain, nausea, vomiting, for example. There will be actually low sodium hyponatremia and hyperkalemia, because what does the steroids do here? We mentioned before, they retain sodium and they release the potassium. So if the steroid level or this adrenal cortex problem, there will be low sodium and high potassium. Okay, so in this way you are going to have dehydration, and this will lead to another cardinal feature, which is unexplained shock. So patient has no trauma, there is no visible bleeding, there is nothing, but patient is in shock. He has high pulse rate, his BP is going down, and you are not knowing what is going on. In this case, you are going to suspect Addisonian crisis. So also patient will have hyperkalemia and is going to have metabolic acidosis. Okay, so abdominal pain, nausea, vomiting, unexplained shock, and hyponatremia and hyperkalemia. Okay, last question, or the question before the last, actually, they are going to ask you about the management of Addisonian crisis. Okay, so in this case here, you are going to follow something called CCRISP, which is care for the critically ill surgical patient. Okay, CCRISP. You can mention it in letters, or as abbreviation, or you can mention it as, I'm going to follow the protocol of care for critically ill surgical patients. So what are you going to do here? First of all, you are going to follow this protocol. Actually, this is not the place to discuss the protocol here. You can read it anywhere else, but this is not the station for that one. Number two, after you follow the protocol, you are going to administer hydrocortisone. Okay, so this is the lifesaver of the patient in this case. Okay, so you are going to give a bolus injection of 100 mgs hydrocortisone. Okay, you can give it IV, you can give it IM, it doesn't matter. And this is going to be followed by one of two options. Either you are going to give 200 milligrams or 200 mgs. You're going to give those 200 mgs for 24 hours as an infusion, or you are going to divide it to 4 doses. You are going to give 50 mgs every 6 hours. It's up to you. Okay, the most important point, 100 mg bolus hydrocortisone in the beginning, and after that you are going to give 200 mgs for 24 hours as you wish, infusion or 6 hourly. Okay, this is the second thing you are going to do. The third thing, so you are following the CCRISP protocol, and you are going to administer hydrocortisone. The third thing, you are going to rehydrate the patient, because patient most probably is shocked and he has dehydration, because sodium, there is hyponatremia. All sodium is going out and the water followed the sodium, so it's going to go out. All the water is going to follow the sodium outside. Okay, no reabsorption here because there are no steroids here. So you are going to rehydrate the patient. So in the beginning, you are going to give the patient 1 liter or 1000 ml of isotonic saline. Please, in any station in the examination or anywhere, don't mention hypertonic saline, please, okay? Because the coagulation is going to kill the patient. So some people mention that I'm going to give 3, because patient is hyponatremic here and is dehydrated, they are going to give 3% normal saline. This is not correct, okay? You are going to rehydrate the patient with 1 liter of isotonic saline, 0.9 saline infusion, and you are going to give this within the first hour, okay? Then after that, within the next 24 hours, you are going to give gradually 4 to 6 liters of isotonic saline also. So in this way, you are going to compensate for the sodium smoothly, and you are going also to rehydrate the patient, okay? So you want to be careful regarding the monitoring the fluids for cardiac patients, for patients with renal impairment. For the elderly patients, you have to be careful regarding this, okay? Definitely this patient is following the CCRISP protocol, and in this way there will be a urine catheter, everything is ABGs will be taken every short period, so there will be no problem regarding that, okay? So as you are doing these points, number 1, you have followed the CCRISP protocol. Number 2, you administered hydrocortisone. Number 3, you rehydrated the patient. As you are doing this, you are going to call the endocrinologist on call, okay? And you are going to ask him to review the patient urgently. He's going to ask you what is going. There is a station for consultant or a senior or a colleague call. It is not the right place here, but the conclusion will be that please review this patient urgently, and he's going to come there and see your patient, okay? So what is the last question regarding the Addisonian crisis and steroid station in general? You are going to be asked about how can you prevent, as a surgeon, how can you prevent the Addisonian crisis, okay? So actually, in this case here, we are considering the patients who are on steroids, okay? So patient is currently, first of all, you knew that the patient is currently on steroids. So there are 2 types of patients who are taking steroids. Some of them are taking steroids with a dose of less than 10 mgs per day, and some people are taking steroids with a dose of more than 10 mg per day. So either less than 10 milligram per day or more than 10 milligram per day. This is number 1. So regarding the people who are taking, or patients taking dose less than 10 milligram per day, you are going to, in this case here, actually this steroid dose is supportive for the HPA axis system, okay? So you are going to assume that they have normal HPA response, okay? So if the patient is going to go to surgery, there is no action required. If the dose is less than, focus on this. If the patient is taking less than 10 mg per day, there is no action needed, okay? So if the patient, now the other side, patient is taking a dose of more than 10 mg per day, okay? What is your action? What are you going to do? So there is a classification for this. Is the patient, ask yourself, if the patient is going to a minor surgery, if the patient is going to moderate surgery, and if the patient is going to major surgery. Everyone has its management. So the patient is taking more than 10 mg per day, and he is going to minor surgery. In this case, you are going to do only one thing. And this thing you are going to do for all categories with some additions, okay? So for all patients who are taking more than 10 mg per day, you are going to give 25 mg hydrocortisone on induction. All of them. All the patients, whatever the class, major, minor, moderate, it doesn't matter. You are going to give all of them 25 mg hydrocortisone on induction, okay? So for the minor surgery, this is the only action you are going to take. 25 mg hydrocortisone on induction, that's it, okay? If the patient is going to run through or to go through moderate surgery, okay, what are you going to do? You are going to let him take his normal dose, and you are going to give the 25 hydrocortisone, 25 mg hydrocortisone on induction, as I told you before. And in addition to that, you are going to give the patient 100 mg per day for 24 hours. So after the induction, on induction, you are going to give your 25 mgs for 1 day, 24 hours, you are going to give 100 mg after the operation for 24 hours. For the major surgery, you are going to do the same. You are going to give this his pre-operative dose, which is taking more than 10 milligrams as usual, and you are going to give the 25 milligram hydrocortisone on induction. As I told you before, you are going to give to all the people who are taking more than 10 mg per day. And in addition to that, you are going to give again 100 milligram, but in this case here, you are going to give it for 2 to 3 days. Okay, so this is the way by which you can prevent the Addisonian crisis. Thank you so much. This is the steroid station. It is a simple station. I tried to explain for you in the best way possible, and actually it is a full mark station. So I'm going to see you in another station, and thank you so much. See you later.